Before lunch, we heard from Dr. Eric Flynn, who is the Chief and Director of the Pulmonary and Critical Care and Interventional Pulmonary Medicine Program at Grady Hospital in Atlanta. He was telling us a little bit about how lung cancers develop, the role of smoking and smoking-related products in the development of lung cancer, and also about the value of screening. We're going to kind of kick things up a little bit, and we're going to hear from some subject matter experts to kind of flesh in a little more details about what's going on as far as some causative agents and things that we can do to decrease our risk for dying, number one, for smoking, dying from lung cancer, and some of the things we can do once we have problems. Our first speaker is going to be Ms. Daisy Ellis. Ms. Ellis is a chronic disease policy specialist with the New Orleans Health Department. Ms. Ellis.
Thank you so much. Hello, everybody. I'm Daisy Ellis. I am with the New Orleans Health Department. I'm very excited to be here today. To veterans in the room, I want to thank you for your service, and I want to welcome anybody who has traveled to New Orleans. I'm going to talk a little bit about what tobacco and smoking looks like in our region and in our city, since we know that where you live can affect your risk for lung cancer and then your access to screening and care. Oh, that's the wrong way. Okay. So why does this matter in Louisiana and in New Orleans? As Dr. Flynn was mentioning, Louisiana has high rates of lung cancer and of tobacco use, and those two things are closely related. We also have a lot of veterans here. About 6% of Louisiana's population are veterans, and most of those people live in Baton Rouge and in New Orleans. So where you live can shape your environment and your exposure to tobacco, your culture of smoking, and your access to care. So Dr. Flynn touched on this. I want to reiterate that smoking is the #1 cause of preventable disease. It can lead to up to 90% of lung cancer deaths and 80% of deaths caused by COPD. In the US, almost 500,000 people every year pass away to deaths attributed to smoking or exposure to secondhand smoke. And this is like a systems issue. This is not about blame or fault on the act of smoking. We have a long history in the United States of the cigarette industry advertising, ingraining tobacco use in our culture, and influencing these outcomes. So what does that look like here in Louisiana and in New Orleans? About 15% of adults in the US smoke. Here in New Orleans, that rate is higher. It's closer to 19%. I know Dr. Flynn also touched on youth smoking rates. In Louisiana, close to 1 in 3 high schoolers have experimented with tobacco products. So we have a lot of tobacco use here. In a report from 2018, the CDC found that close to 29% of veterans reported tobacco use. So veterans have an even higher likelihood of smoking and of using these products. Our state is also part of something called Tobacco Nation. Tobacco Nation is a set of, I think, 12 states that have higher rates of smoking than the rest of the country, and we also have higher rates of lung cancer and then lung cancer deaths. This map here shows what those states are. You can see it's mostly through the South and the Midwest. And this also affects our rates of heart disease and other tobacco-related illnesses. Historically, these places have higher tobacco use and fewer protections, and they might have environments where tobacco is accessible or ingrained in the culture. This is a little bit about Tobacco Nation's statistics. This is from the Truth Initiative. You can see the areas in Tobacco Nation have a smoking rate that's higher than the other locations in the US. And then on the right, it's information about our lung cancer incidence. And our lung cancer incidence across this region is 69 people per 100,000 people, whereas in the rest of the US, it's 52. So this issue of lung health is really near and dear to our hearts in Louisiana. Even more locally, so I work for the New Orleans Health Department. I work a lot on tobacco access and youth access right in our city specifically. And one thing that we have that affects our health outcomes is a lot of tobacco retailers. In this city, we have over 600 locations that sell tobacco. A lot of these are convenience stores or gas stations. About 20 of them are specifically smoke shops or vape shops. This doesn't even include like the hookah lounges like Dr. Flynn brought up or cigar bars, which we still have here as well. So having this many locations and this much density can make it easier for people to start smoking or can make it harder for them to quit. So it really matters how accessible tobacco is when people are understanding their risk, their likelihood of smoking, and if they're trying to quit. I'm sorry. I'm not sure. Okay, I had some other slides, I think, but it might be ready to turn over. I just wanted to talk about, we do have some opportunities for improvement and some room to grow in our cancer screening and treatment and access to care here in Louisiana. We have high rates of new cancer and we have low rates of early diagnosis, as Dr. Flano touched on, but I don't know what's going on with the clicker. I'm so sorry. But my colleague, Mr. Wellens, is going to talk a little bit about, given our landscape and the prevalence of tobacco, what resources there are to quit and for cessation. So thank you so much.
Well, Daisy, I'm not certain what happened. I just wanted to make clear that I was sitting back there and I had nothing to do with that one. But thank you very much. And I want to remind you that we'll have an opportunity for question and answers at the end with all of the panelists. Our next presenter is going to be Mr. Bradley Wellens. Mr. Wellens is the regional manager for Southeast Louisiana Tobacco-Free Living, a joint program of the Louisiana Public Health Institute and the Louisiana Cancer Research Center. Mr. Wellens.
Thank you, Wayne. And it's nice to be here. Thank you. I work very closely with Daisy and a lot of the tobacco cessation and veterans work here in Louisiana. And I'm going to flip through these fast because one of the things we want to do is I want to focus on some things where are the gaps and things that haven't been talked about. But tobacco control for veterans, oh, there we go. Other way, there we go. Daisy talked about why tobacco is important, but it really want to talk about why the topic is important for veterans and with lung cancer directly. One of the things that we talk about when we're looking at these statistics is these statistics are based on surveys of enrollees within the VA and identifying veterans as to how we came up with these. So when we talk about the tobacco statistics here in Louisiana and in the United States, that these are surveys that are done specifically for veterans. And so when you know this, is like when you're comparing the veterans and the general population, that's why the reliability of these surveys. Dr. Eric did a great job of pointing out where were the differences between the Louisiana population and the veteran population, particularly as it relates to lung cancer. Let's see, get through that. Okay. One thing that has not been discussed, and this is where we talk about veterans, is veterans are a really hard group to reach in terms of both tobacco use and, importantly, screening and tobacco screening, because where a lot of the stressors for their initiation into smoking and tobacco use come from their military, come from stress, reaction to combat, and identity crisis, particularly as they move from active duty to veteran to being home. It's a reaction to that, and that's one of the things that's very different from smoking in the general context. So these are, this is numbing the pain, peer pressure, easy access, and then how to connect. And then that's one of the things that we talk about at TFL is how, and making that gap between the services that are available with the VA and the services that are available in general, but how they have veterans connect to it. And one of the ways that we do that is to try to have veterans, we have to meet the veterans where they are. And that's the biggest thing that if you can take away one thing from this is that that the services exist, but there are gaps because the veterans aren't taking advantage of those services, particularly within the VA. So there's a focus of veterans with disabilities, and why we do that is because most veterans that come back have some form of disability, particularly if you're qualifying and having the lung cancer or even having the smoking, it allows for the disability to be there. Talk about smoking rates with the mental health, there's substance use diagnosis, and then what tobacco treatment means, And we really, the biggest thing to understand is that this is tobacco treatment within a holistic scheme. And one of the problems is that people are so often focused on tobacco care and tobacco treatment without understanding it happens in a larger sense. So this is some of the work that we've done here at the Alexander Vet Center here in New Orleans, and we've done all kinds of talking about gaps and access to barriers. And then we've talked about tobacco use statistics in Louisiana. And then one of the things that TFL does along with the state, we have access to a quit line that's separate from the VA system. This is free. And so what we do is we have where the access to that free quit line to connect the veterans up. One thing the next step we need to take is identifying who's calling in the quit line and how to make specialized references from there. But that, we're kind of slowly getting there. We're understanding what is effective and what's happened for the veteran. And then the last thing is this is a utilization where that's exactly what I'm talking about. It's where the veterans are not using it or how we find out they increase it. And then how do we connect from the services that are available for the quit line and the veterans with the lung cancer who've done the screening to the VA. And that's become what we've realized is that's the biggest disconnect, is where the services are available, but in some cases they're not being utilized. However, these are the services that are offered by the Veterans Administration, the support services, the Veterans Quit Line, telehealth, along with the smoke-free vet program. And then this is you can do it via email, you can sign up on a computer, you can do it via text, you can call in. It's if it's utilized, it's a very effective program, but that's the big if it's utilized. And so one of the things we try to do is to try to point people to Alton, and like I said at the beginning, meet veterans where they are. And this is just a different thing to talk about. But yeah, so the biggest thing here is to really understand that the services that are available for the veterans, there's a wide variety of them. But the key is, who do they listen to? And what we found is that veterans are primarily listening to veterans themselves. So if you can find access, whether it be at a clinic or whether it be a way to involve peers of veterans talking to veterans, that's going to be the key to success. So, thank you.
Thank you for that. Thank you very much, Bradley. And as you know, things we're talking about as far as veterans also impact other people too. So bear that in mind, that we are, of course, concerned about the veterans in this session. Our next presenter is going to be Ms. Lindsay White. Ms. White is the director of the Tobacco Cessation Program at the Ochsner Healthcare. And I mentioned earlier, and this morning when we introduced everybody, she probably affected or responsible for 27,000 people having touched as far as smoking cessation, which I find remarkable. So she's going to give us a little talk about that. Ms. White.
I do not have slides. So a little bit about the Ochsner Smoking Cessation Program and then kind of resources around the country. So Ochsner was able to start that program in 2012, 2013 with the help of something called common law Napoleonic law in Louisiana. Our personal rights were infringed on, which allowed for about $187 million to be put into a trust that was used to only allow for people to stop smoking. And so that's really what started the Ochsner Smoking Cessation Program. With that, we were able to create 15 clinics in the first year. We're now at 33 clinics across 2 states, so that includes Mississippi. As he stated, I've seen 27,000 unique patients, and we have an average quit rate of about 30% at 12 months, so we're far above the national average. Why are we so successful? I think the key to everything is repeat, 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 which means you don't want to quit today, you may want to quit tomorrow, you may want to quit a year from now. So the key is to continue to ask the question. So for us, ours is put into our best practice advisories within your healthcare system. So when you guys come in every year and they say, hey, do you smoke? And you say yes. Then we say, do you want to quit? And we hope you say yes. And if you do, then you are put into our program. I think the other key to making programs successful is you have to reduce all barriers. So everything is free. So the counseling is free, most of the medications are free, and Ochsner committed to making sure Chantix was free to all patients. So if you are a veteran and you're frustrated because it takes a while to get through the VA, I'm going through that right now with somebody, you can come to Ochsner. We don't ask for your insurance, we don't ask for anything, and you can seek all of our services for free. And then we will help you with any of the over-the-counter medications or medications. So that's, I believe, why Ochsner has been more successful than some of the other programs in Louisiana and even across the United States. Other programs in the state, though, if you like LSU, LSU has a great program. They've been doing it for a number of years. There's always the quit line in every state that can help you, guide you to resources that are available in your state. And I know North Carolina, Texas, Georgia, all these different places do have specific programs for specific groups of people within their hospitals or their communities. So those are also really great ways to connect with people that need to quit. Again, don't give up on your partners. I always say that, and spouses, children. You never know when they might quit. And our biggest story is we just had somebody that said no to us 23 times. Over the last 10 years. And then his mom died of lung cancer, and he came in, and now he's 2 years quit. So you never know when that moment's going to be there that that person wants to. And so just keeping those doors open and that communication open really does make a huge difference. The other part that you need to consider always is the lung cancer screening. Early detection is key. So again, with Ochsner and almost all healthcare systems now, there is a way that we can actually document. If you tell us that you have a 15, 20-year PAC history, then you are referred to the early lung cancer screening. Now, you do have to go, but once you do, you'll be in the system to be continually checked on whatever basis they believe that to be necessary. And I always tell people, advocate for yourself. So if somebody's not asking you those questions, you need to then ask them, hey, am I eligible for these things? Because they are free. Almost all insurance now covers those. So again, for Louisiana, Ochsner does have one of the bigger systems. LSU has a program, Lady of the Lake has a program, and you can always call 1-800-QUIT-NOW, and they can direct you to any type of resources. Thank you.
I think the take-home point there is there's nothing wrong with failing. You can try it again, try it again, try it again. Well, that's pretty good. Again, I'm going to remind you, at the conclusion of formal presentations, we're going to open things up and have a Q&A session for us all. Our next presenter is Lisa Jordan, Esquire. Ms. Jordan is a professor and the director of the Environmental Law Clinic at Tulane University Law School. As we said earlier, she was part of the she'll tell you. She was part of the Environmental Justice Advocacy, which is a group advising the Environmental Protection Agency up until 2025, unfortunately. However, Ms. Jordan is going to give us a presentation. Ms. Jordan.
And justice for all. The last 4 words of our Pledge of Allegiance, and a lofty goal for this nation. We represent clients for whom environmental justice is not yet a reality. Clients along Louisiana's Cancer Alley, as Dr. Flynn referenced it. It's a 184 river mile stretch of the Mississippi River. You'll often hear it referred to as 85 miles, but it's 184 winding Mississippi River miles. And it's a stretch between New Orleans and Baton Rouge of about 5 parishes. That's our equivalent of the rest of the state's counties, where there is a conglomeration and a concentration of petrochemical facilities. And our clients, grassroots groups in these areas are fighting for justice. They're fighting for health justice, and they're fighting for environmental justice. And that's where their stories in this conference links. They're fighting for lung health as well. They're fighting for overall health. And they have quite a battle in front of them. We are honored at my clinic, myself, other faculty, and students, to actually represent these groups in court and before agencies to help them try to achieve this goal. Our clients speak and advocate before the agencies of the state and the local government and the United States government to try to get environmental justice. And the goal that our clients are trying to achieve is to be treated equally and fairly. The concept of environmental justice, which was first sort of put into an executive order under President Clinton, is that no group of people should bear a disproportionate burden of pollution. And in Cancer Alley and other communities like the Mossville community outside of Lake Charles, they are bearing a disproportionate burden of the pollution from industrial operations. They're fighting for clean air and they're fighting for clean water. They've spoken, as I said, before the EPA, before the state and local governments. It might not surprise you to know that those entities don't always listen. And that's where my clinic and my students come in, because we represent these individuals and these organizations in court, the third branch of government, where a neutral decision maker or decision makers can decide, and where anybody is equal to anybody else. So courts are critical for this fight for our clients, and they've won some of those fights. So what our clients really want to expose is this disproportionate burden of pollution that means that Black communities in these areas, again in Cancer Alley and in the Lake Charles area of Mossville, have a disproportionate burden of pollution. So take the 5th District in St. James Parish. It's on the west bank of the Mississippi River. Based on 2023 data from EPA's now deleted EJ Screen database, the 5th District is 88.6% Black. It ranks in the 89th percentile statewide and the 95th to 100th percentile nationwide for air toxic cancer risk. That means people in this district have more risk of developing cancer from air toxins than 95 to 100% of the people in the rest of the country. They're also in the 90th percentile for air toxics respiratory hazard, again, lung issues. What about the 4th District of St. James Parish, just across the river? Ranked 95th percentile statewide and 95th to 100 nationwide for air toxic cancer risk. In the community of Mossville that I mentioned in the Lake Charles area, again, very high risk. They're in the 99th percentile in the state and country for toxic releases to air based on toxicity-weighted concentration. So in our clinic, as we've been representing these clients, we've realized that we really need some science to back us up. We need science to prove the lived reality that our clients have known for decades. We're getting sick. We're getting sicker than other people. We know this, but we needed evidence. So my clinic started a science-based advocacy program, and the program does studies and focuses on some issues that really no one else is focusing on. And I wanted to just mention a couple of these studies. The first study we did was during COVID, and it was a study that was co-done with someone from the University of Memphis, and it was called Racial Disparities in Air Pollution Burden and COVID-19 Deaths in Louisiana. And its major finding was that higher levels of air pollution were associated with increased COVID-19 mortality or deaths. And it was consistent with other studies nationwide that found the same thing. It also found that measures of particulate matter, which is one of the forms of pollution that our clients are exposed to, it's basically soot, that they were higher among census tracts with larger portions of Black residents. In 2022, our program published a study, Air Pollution is Linked to Higher Cancer Rates Among Black or Impoverished Communities in Louisiana. And the finding was basically that. Higher estimated air toxics cancer, risk was associated with higher cancer incident. So again, demonstrating the disproportionality. And then in 2023, finally, there was a study entitled Discriminatory Outcomes of Industrial Air Pollution in Louisiana. And it found that census tracts with permitted facilities by the Department of Environmental Quality, industrial emissions were 7 to 21 times higher in predominantly Black communities compared to predominantly white communities. So we're using these studies to make our case before decision makers. I want to end just by mentioning one case that I thought y'all might find particularly interesting. It's actually not a case in Cancer Alley, but in Colfax, Louisiana, which is near Alexandria. And the group he represented there was called the Central Louisiana Coalition for a Clean and Healthy Environment. So these folks, and again, this isn't what we call an environmental justice community, they live on the border of a facility called Clean Harbors Colfax. This facility contracts with the Department of Defense and other entities. It disposes of munitions like TNT, rocket fuel, hand grenades, claymore mines. I had to look that one up. But basically, they dispose of them by exploding them, by detonating them. And they do it out in the open. They're the only facility in the country that is allowed to do this out in the open, big concrete parking lots. They explode these things, and this community lives right on the fence line. So this community had some success advocating for themselves and got the state to restrict the company, to force them to do a clothes burning method. That progress is not yet realized because the company sued the Department of Environmental Quality, so they wouldn't have to do this in a closed system. But it's been a success so far, and we're crossing our fingers that the court case works out. But we're really honored to represent these folks, and they're fighting for their lung health as well. Thank you so much.
Our next speaker is Mr. Billy McDonald. He is a cancer survivor. Remember, we talked about in 2017, he was diagnosed with lung cancer, treated with chemotherapy, and since now he is cancer-free. And since then, he's become a major advocate, not only for cancer treatment, but early detection and screening. Mr. McDonald, please share your story.
Hello. Well, I am a veteran of the Vietnam era, and many people do not know, but prior to the Vietnam era, when you went out into the field for field exercise, you was giving your food for the day was a lunch box, was called C rations. Within that box of C ration was something to contribute to smoking while you was there. Each box had a pack of cigarettes in it with like 3 to 4 cigarettes per pack. And the big deal was to trade off what you want, to get the kind you want. Now, mind you, that's not when I started smoking. I started smoking at an earlier age because I did what everybody else was doing. I wanted to fit in. Well, as life passed on by, I was introduced first to an early screening exam at my wife's job. And in 2014, I went and had the screening done, and the results came back negative. So I thought I was good to go from then on. But in 2017, I get this phone call about a screening. I said, nope, I can't do it. I can't come back. I've already been diagnosed negative. Well, 2 weeks later, I get another phone call. I said, nope, I can't do it. Well, 2 weeks later, a phone call came, but it went to my home. And when it went to my home, my wife received that message, and my life changed right then. She made it clear that this is something that I was going to do regardless of whether I wanted to or not. It was free. Well, why not take advantage of it? It's for my health. So I went and took the screening. Needless to say, they discovered a small spot on my lungs, 1 centimeter in diameter. And I looked at the doctor and I said, well, I just had this test 3 years ago. He said it don't take 3 years for it to happen. It could have been the next day or the next week, but it's there. So we are going to remove that. So they did a biopsy. They took a wedge out of my lung, and they examined it and tested it, and they found several lymph nodes. One of them tested positive for cancer. My life changed. My head was in a whirlpool. I thought of all the things I should have, could have, and would have did. and how I was going to get through this. And he said, well, your blessing is that the cancer was already removed from your body. I was set to have an appointment for radiation. Radiation doctor said, you don't need radiation. You've already cancer has been removed. So I had several rounds of chemotherapy. After chemotherapy, and I became cancer-free, I was allowed to go back to work in 2018, and I retired from my job in 2019. And as of today, I am still cancer-free. I've had to take screenings every 3 months from 2018 up until probably about 3 years ago. Every 3 months, I had to go take a CT scan and an MRI before I could see the oncologist. And I did not know that if I didn't get those tests done, the oncologist was not going to see me. Until one day I went there and he said, well, we don't have no results from you. I was like, what are you talking about? You didn't have a CT scan. I said, nobody scheduled me one. He said, well, I can't see you. So you go back out there and tell them to schedule you a CT scan. When you get it done, then I'll see you. And I was like, is that important? He said, it is that important because cancer don't wait for no one. It comes when it wants to. He said, and we want to make sure you're clear. So now, all my appointments is stretched out to 1 year instead of 3 months. So, glory be to the Lord. I'm still cancer-free.
Thank you very much. Mr. God, thank you very much for that. I want you to see me. Based on what we've just heard from, try this now. Okay, thanks. It's amazing. I'm a colorectal surgeon. You know, as a patient of mine said, Dr. Tuxson, I know you're not very bright, otherwise you'd been a heart surgeon instead of a colorectal surgeon, but I like you anyway. So we're not very smart colorectal people. So what we've just heard, I think one of the things that Dr. Flano said earlier this morning was effectively there are no early warning signs of cancer. So Billy, if you and Dr. Flano could share that microphone and you let Dr. Flano answer. So since there are no early warning signs of cancer, how can you make an early diagnosis of a cancer?
The best way currently is to get the screening. It is a once-a-year CT scan.
What does screening mean, though?
So screening means we're looking for it in the early stages before it causes any symptoms, any of the symptoms we pointed out earlier, that I pointed out earlier. So you're trying to find it before it comes active and before it has spread. The best way to do that now is through a CAT scan. It's once a year. It is very low dose in radiation. It takes from the time you get there to getting out, and this is check in, 30 minutes, get into a gown, get on the table, and leave out. It's about 30 minutes. The results will then get read by the radiologist and sent to your primary care physician, who will sit down with you and discuss what they found.
So, Daisy, Dr. Flano just told us about, or Eric just told us, I'm calling everybody by the first name. I don't feel like saying doctor no more. So Eric just told us about the screening thing. So how does that fit in with a statewide coordinated effort, or does it?
Hi. I think that, so Dr. Flano is a clinician and I'm on the public health side, and I think those two things really go together. We need the medical system to be serving each individual patient and giving access to screenings for each individual patient. And then on the city or state or government side, we need to be seeing what we can do to prevent people from starting to smoke, to make tobacco harder to access, to make tobacco less of a part of our culture here, and to make sure that people have also the resources they need to afford care and be able to get to care with transportation, time off, those kinds of things.
That sounds good, but Bradley, Louisiana, like Kentucky, a state which you're familiar with, makes money off of cigarette smoking. We have tobacco farmers. It is an integral part of the environment or the economic environment. So how do you convince a state legislature that we need to back smoking cessation programs?
Yeah, and that's a great question, and I think that it's a matter of changing the culture and changing the the accessibility or acceptability of it. It's like whether smoking is a part of our culture, it's a part of being at the in the active duty military or a veteran, and then recognizing that like there are other things that like it's not okay. In other words, that if you're doing it for whatever reason, if it's mental health or if it's your exposure or whatever, then recognize that you're going to take care of the whole health of the veteran, and that's kind of how we've been approaching it. Not to say that it's bad. And so one of the biggest things is that it's a change in attitude. And I think we're seeing this a little bit with the younger veterans. We're seeing this a little bit with the younger veterans. And the younger veterans are realizing that it's really okay to try to address all of their health, whether it be with mental health, with PTSD, with tobacco use, any of that. And then that's kind of the fundamental change. And so what we're trying to do is to take what we've learned, the lessons we've learned from that, particularly as a treatment for like suicide and PTSD, into tobacco and into, like Dr. Eric said, getting the screening and identification of it early. Because the earlier we catch it, the better off we are.
Yeah, but I'm a state legislator, and I got somebody who makes their money off of smoking. Give me your experience in Kentucky. How do you convince somebody to say, hey, we're going to put a tax on, or we're going to do something to take away part of our economic engine?
And that's the thing. What we found when we're working with, when I go out and work with veterans and work with veteran groups, is that the people they listen to are the people that A, they're closest to, whether they be family and friends, or B, their peers. And the veterans listen to other veterans much more so than any other. And so one of the things we tried to do is to create a network of peers for veterans.
But who do the legislators listen to?
Yeah.
That peer group is very select, so tell me about that.
Well, I
Good
can maybe
point.
help with this since I do state and I'm on the federal front for this too with Medicare. It really does come down to dollars. So the way you have to present to your legislators is that healthcare cost around lung cancer is exorbitant, and that if
What kind of costs are you talking about, by the way? And are you speaking just purely dollars and cents, or are you talking about emotional and physical costs?
No, I'm talking dollars and cents is about $240 billion in smoking a year. So that's across, and we're not even talking about loss of work productivity or your loss of being able to be available to your family or anything like that. So when you talk to any type of legislator that talks about the cost of healthcare and what the single factor of reducing healthcare cost is smoking, that because it is a life choice. And when we talk about people with cancer, 80% of cancers are lifestyle choices, right? So obesity, we don't work out, we eat bad food, we smoke, we do bad things. 20% are the ones that just kind of happen to you. So if we can be healthier, stop smoking, exercise more, then we're going to reduce those things. And to her point, obviously there's environmental issues. So I know on the federal front right now, we're dealing with Medicare. That is the biggest issue right now, is the cost that we can reduce out of the cost of Medicare if we can get people to stop smoking.
All right, Daisy, she avoided my question, how much it's going to cost an individual. Give me that answer, please.
Well, I can't help this.
No, you don't get off of it. I want to know how much is it costing the individual? How much are we speaking per, about ballpark? If not, I'm going to have to ask Eric.
I don't know.
But
The
go ahead, you can
individual
respond
cost.
then. All right.
I did just want to say about the legislators, though, like, to what you can say to a legislator, somebody like me can come in and have numbers and facts, and that's fine, and maybe they will want to listen, but when a cancer survivor comes in and tells their own personal story, or a family member, that tends to get people's attention a lot better. So if there's anything going on in your state for tobacco taxation or cessation services, and you can go tell your story, that's going to usually affect the legislators' vote a lot more than having like public health people or government people come and talk about facts.
Dr. Flano, what is the difference between finding a small cancer with screening or doing screening versus treating a patient with lung cancer? Any day.
Test. Okay. So the difference is, it's a lot, if we're talking dollars and cents, we were just talking about a little while ago, it's a lot cheaper to treat an early stage cancer, especially if it can undergo surgery and reach cure, than it is to treat a late stage cancer just across the whole healthcare system. Because you can get surgery, can be treated and reach a level of cure, which is where we're all trying to do, or remission, because we never really say they're 100% cured. And if you can achieve that, it's cheaper than going with yearly, 3 times, 4 times a year CAT scans, MRIs, chemotherapy, and all of the rehab. So that is one beneficial aspect of it.
Mr. McDonald, how much were you spending on cigarettes per day, per week, per month?
It was pretty much per week.
Just hold it to you. Now hold it in front of your mouth now.
Okay, I would say probably between $7 and $10 a week, because I did not smoke a pack a day. Because most of the jobs I had, you couldn't smoke on the job. So you had to do it at smoke breaks, but they gave you smoke breaks, and that's what it was called. So it was like maybe every 2 to 3 days a pack. So at least $10, $12 a week.
So, Lindsay, given that his cost, what's a typical figure that people are spending for cigarettes? And one other thing, when you answer that, I don't get mad at a patient who has pneumonia and continues to cough and has to come back in and get treated again. Why do we have a different attitude for the person who tries to quit smoking but has trouble doing so?
Okay, so first part is the average cost. So average cost right now, Louisiana is very inexpensive because we don't really have great taxes on it. So we're running about $8 a pack a day, so times 7, that would be $56 a week minimum. And in Louisiana, we have 6-pack-a-day smokers, so if you can imagine the amount of cost for some of these people to be smoking, they could buy a new house. Second question is why do we do that with any type of addiction? We, in healthcare, especially our physicians, we give you a pill. Let's just say you said bronchitis or pneumonia, and you're supposed to take that medication, and then you're cured, and if you don't, we'll give you a stronger medication, and then you're cured. Addiction does not work that way. So with smoking, there is so much complexity to it. It's not just physiological, it's also mental and behavioral, and it has a lot of aspects to it. So it's really important that physicians just continue to encourage, and it's really important that healthcare systems create opportunity where there is a group of people that have specialization in this. We call them tobacco treatment specialists, that they spend their time really working with the patient and give that time in consideration, and we can follow up, and that allows the physician to continue doing what they need to do. So highly recommend that if you don't have a program, that you look at how can you fund one. And 2, for any type of physician, just keep encouraging your patients to try to quit, because we'll get you there. We just need you to start believing in us and, us and you. And the crazy thing about nicotine over heroin and some of the other drugs, the more times you actually try to quit smoking, the more likely you are to quit. It is opposite when drug addicts like heroin and stuff like that, the more times they fail, they're probably gonna not do well. But with nicotine, it is the opposite, so keep encouraging.
Surprisingly, I remember back in the 80s, back when I was in DC, heroin addicts said it was easier to quit heroin than it was cigarettes. Go ahead, Bradley, you want to comment?
One thing that I think Dr. Eric's presentation brought out really well is the nicotine that we're smoking, or what we're smoking now, is not what we used to smoke. In other words, that the cigarettes having 8 milligrams of nicotine versus, as Dr. Eric said, you saw those pods that were going up into Sharon, which has over 100 cigarettes in one pod, the equivalent of nicotine. So not only is it's an addiction, but it's an addiction which we're feeding by giving more nicotine, and so it's even harder to break that cycle. But you're right, there is hope there, because the more times you kind of try to quit, the more likely you are to succeed. I think the average number of quit attempts is 6. It's really high.
9 to 12.
Wow.
9 to 10. Okay, Lisa.
Yeah.
Lisa. I don't smoke. I get my house checked for radon. You can pick up the microphone, because I'm going to shut up in a minute. I promise you. I don't smoke. I don't have radon in the house. Nobody else smokes in the house either, so I don't have secondhand smoke, don't have tertiary smoke. Why does where I live have a greater impact on my health than my genetic code?
Because of what you're exposed to if you live in an area with industrial facilities that emit pollutants into the air over levels that are considered healthful. And that is the case in a lot of, as I said, Cancer Alley, is people are well, I shouldn't say the people are concentrated because the people were there first. But the facilities that emit these pollutants that you don't have a choice but to breathe. That's the problem is you don't have a choice but to breathe the air. And so if the air around you is toxic and can cause cancer, then that's certainly an increased risk, and that our clients are experiencing.
So you have this information. The person who is your public health commissioner and your state health commissioner and the person who runs the Medicaid services in your state has this information. And we know it costs a lot to take care of these people. We've already heard that. So why are these conditions allowed to persist? Is it that we say a certain segment of our population is disposable as opposed to the income of the state?
Well, I would say that our clients feel that way. I can definitely say that. They feel that they are not listened to. They feel they are not valued. They feel that the money from these facilities and the power that these entities have more value to the decision makers. There's another issue as well, though, and that is the Louisiana Tumor Registry, which is sort of the official record of cancer, cancer incidents. It doesn't reflect this, and the reason is because it doesn't look at industrial exposure to industrial pollutants. So it's not going to reflect it. So a lot of times they just point to the tumor registry and say, there's no evidence of cancer in these areas, and that's why the science is so important.
Stanley, we have a question.
Good morning. Thank you all for your time and sharing all your information. My question is for Dr. Eric, and somewhat it's been answered, but I wanted you to elaborate on what is screening, which you did, and then I wanted you to walk us through from screening to diagnosis to treatment. What does that look like? And then the second part of that I want to say, which I haven't heard from anyone, what are signs and symptoms? If I'm not going to get screening, what's going to bring me to the doctor?
Thank you very much.
We'll start 2 to 1 then. Signs and symptoms, if you really don't want to have the signs and symptoms, right? If you do have the signs and symptoms, you need to get with your primary care and be seen pretty early. What you want to do is know what the risk factors are for screening, and if you or you know somebody that qualifies for the screening, discuss it with your primary care doctor so they can get you into a program that does. And that is being between the ages of 50 and 80, having smoked, as I explained, a 20-pack year or more use of cigarettes or tobacco, and then having smoked any time within the past 15 years. If you meet those 3 areas, then you are a candidate to get screened. The purpose of screening is to find it before you have any of the symptoms. So when you have those criteria, meet those criteria, and you talk with your primary care, they'll talk with you about, is it worthwhile going through all this? Are you ready to commit to going through the screening? And then you go through. It's, as I mentioned earlier, once a year, a CT scan, and then they will get the results back and they will follow up. Now, if they see something on the CT scan, then they will refer you to a specialist who can evaluate it. It may be a physician or a surgeon or a combination thereof that can either get a biopsy or have it removed if it has enough suspicious characteristics. And then from there, based on the results, is how you will plan the treatment moving forward. Okay.
Billy, would you remind us why you got how your diagnosis was made, please? How your diagnosis of lung cancer was made, please. You can take the microphone.
After the CT scan,
Feel free to talk to the
after
microphone.
the CT scan, I had an appointment with a.
Yeah, but why did you have the CT scan?
Why?
Why? Yes, sir.
Because my wife suggested, because I was a smoker for a long period of time,
Okay.
and I was in the service, and I've worked at several jobs where there was certain exposures to different things. So she suggested that I go and have this screening done. And I was like, for what? And she was like, so that you'll know that you don't have something going on in you, because you've been smoking for so long. So after the first 3 years, I thought I was good to go from then on. But 2017, it changed.
Well, Mr. McDonald, you truly did marry wisely, sir. You married like me, above your pay grade. Okay, come on up. One more question.
I have a comment. Good afternoon. Very quickly, Dr. Tuckson. My name is Janie Blackman, and I'm a local resident here in New Orleans, and I'm grateful to HEAL and the veterans and all of you here today. But I'm a non-smoker. I've never smoked. And I encourage everybody here today to listen to your bodies. You know, when things happen, I had a nagging cough. I'm not a doctor, but I thought it was sinus, this, that, and the other. Make a long story short, my cardiologist, who was just a phenomenal man here in New Orleans, said to me, he said, girl, you got this nagging cough. You need to go see a pulmonologist. And I said, well, that's probably just sinus drip. However, I listened, and I saw a pulmonologist. 2 or 3 years prior to seeing him, I had pneumonia. So they thought it was just scar tissue. But I went to Oxnard, New Orleans, girl, you know how we pronounce. And I had, you said a scan or a screen done. They did a biopsy. And so the doctor came in and he said, I have good news and bad news. You didn't have a stroke, but you have a malignant, it's called small, you said it earlier today, carcinoid. Yes, I never heard of that before in my life. Never smoked, never drank. But the blessing is God is so good because I listened to my body, the coughing, the excessive coughing, the sinus drip, and then I listened to my doctor. I'm here after 4 years. My great phenomenal doctor, Dr. Brian Pettiford, will be here this afternoon. I had a 5-hour surgery. I was paralyzed for 7 weeks. I'm grateful to God, but I'm very thankful. And I want to be an advocate because here in Louisiana, in New Orleans, we smoke, we give away money to die. So we need to get the word out about this. You know,
What parish do you live in?
Orleans Parish.
Thank you. So, first, congratulations. All right, Dr. Flano. So you heard this thing. Listen to your body, because sometimes, let's face it, some healthcare providers don't always seem to listen intentionally. So how do you address that, man? I think your perseverance. So tell me.
So a lot of healthcare today, I kind of see is they've been moving it a little bit more from being truly a practice to a business. And with that, you kind of have restraints and time restraints. And we recognize that's across the board anyway. But a few things to be is a lot of times you have limited time, but you need to kind of prioritize a lot of the things that you want to bring forward.
Person comes into you sick. You gonna tell me you got limited time?
I'm not going to tell you that, but you know, one person out here say they don't feel like they have limited time when they're doctors. Please raise your hand, because it is that way. But what we really need to hear to really focus in on what you're experiencing, is what you feel is important or what has changed from your baseline. You know your bodies, and if something's not right, we need to hear that. The other encouragement I give is, a lot of times you may not want to, but it might be good to bring that husband or wife into the appointment with you, because sometimes they see things that you don't feel are important, but it comes out. And sometimes those little changes, those little additions to how you're being seen can make a difference to how we make and prioritize how we move forward with your care.
And later, before you answer, I want to remind you, one of the sessions tomorrow is going to be on AI. And unlike our education secretary, I'm not talking about A1 sauce, but AI, in which we're going to talk a little bit about that, because a lot of us are relying upon Chat, GPT, Claude, and a few other things, thinking that we're going to be getting great advice. And as they say in Porgy and Bess, it ain't necessarily so. Go ahead, Lisa.
Well, I did want to just add to that because I think we go to the ER a lot thinking that they're going to help you with that cough or something. And the truth is that this is where avocation comes in huge. The ER is just there to make sure you don't die that day. They don't care that your cough has been going on for 6 weeks. That's really where you need to get with your primary care or some specialist to have a conversation with, because as long as you're okay that day, they just send you on your way and you think you're then fine, because they gave you an x-ray, but they didn't do the detailed work that needs to be done. So again, making sure you get the right care at the right place at the right time is really key, because we sometimes use the ER thinking that they're gonna help you, and that's not their
I
job.
always thought the ER was where you go to get a CT scan done. But anyway, I want 1 minute response, take home point. What is your one take home point? Starting with you, Daisy. Take home point, that's it.
My take-home point is that lung health and tobacco is a cultural systems, large-scale issue. It's more than an individual responsibility. Try to advocate for policy that reduces tobacco in your communities to advance lung health.
Bradley, the one take-home point.
The take-home point for me would be to really understand that, particularly in the context of veterans, how much tobacco use and the culture of smoking and tobacco use within the military and then within the veteran community need to change. And that the veteran needs to be talking to each other to access the care that's available, not just with the VA, but with other services, cessation services, and then things like that, to really understand how do we, if I've smoked and I continue to smoke, I know that that's out there, and how do I protect myself and protect my family by making those right choices.
Take home point.
Don't give up, keep coming back, we'll eventually get you quit, and then keep encouraging. So if you have family members that need to quit, just keep encouraging the space that they can do it.
All right, Lisa, take home point.
Be an advocate. Be an advocate for yourself. Be an advocate for your loved ones. Don't be afraid to irritate. In your case, maybe that's a doctor, right, whose time is up. Don't forget to insist on those last couple things you want to know, coming from the lawyer who's used to irritating judges. Be an advocate.
Be an advocate. Billy.
Early screening is very, very important. And make sure that you contact a doctor if you have any symptoms in your chest going on. Say, I want to get a screening. And usually that'll lead you in the right direction.
Eric.
Educating yourselves and those around you about what you've heard and what you've learned today is extremely important in terms of being able to make decisions about your health for each other. And that there's a lot of stigma around smoking, but keep in mind that screening you should go in that with no blame, no shame, because it will save lives.
If you don't smoke, don't start. If you've started, quit. If you are a smoker, get screened. If you live in some place where there's a high cancer rates, you're screwed. Fight the fight. You got to fight, fight, fight. Ladies and gentlemen, let's give our panel a hand, please. This concludes this afternoon session, and I want to remind everyone we'll be back here again tomorrow morning, and I look forward to seeing you, and thank you very much for your wonderful questions and being patient with us today.